All right, welcome everyone. In this explainer, we're going to dive deep into a high-yield clinical review of obstructive sleep apnea/hypopnea syndrome. Whether you're a clinician in practice right now or maybe you're gearing up for your specialty exams, we're going to walk you through the entire clinical pathway, right from that very first suspicion all the way through to evidence-based management.
And just so you know, all the fantastic information we're covering today is based on the comprehensive work of Dr. Mohammed El-Nagi Mohammed. We're actually going to follow his clinical pathway approach to really get our heads around this super common but, often underdiagnosed condition.
Okay, so let's get right into it. Here's what's on the agenda. First up, we'll cover the basics. How do you even spot OSHS in the clinic? Then, we're going to look at who's most at risk and really understand the serious consequences of this thing. After that, we'll nail down the absolute gold standard for diagnosis. And finally, we'll wrap it all up by reviewing the latest evidence-based management strategies that you can actually use in your practice.
All right, Section 1. Let's start right where it all begins, that initial encounter with the patient. Recognizing OSAHS, well, it often doesn't start with a fancy test. It really starts with just listening. Listening carefully to the patient's story and picking up on those classic signs and symptoms that should immediately get your clinical senses tingling.
Now, here's something that's really interesting. The patient themselves, they're often an unreliable narrator of what's happening during their sleep. I mean, they're asleep, right? It makes sense. And that's exactly why the most critical piece of this whole puzzle often comes from their partner. They're the ones who might report that incredibly loud snoring, or even those terrifying moments where the person stops breathing altogether. It's just a powerful reminder, isn't it? The importance of getting that collateral history whenever you even suspect a sleep disorder. Okay, so your clinical suspicion is officially raised. What's next? Well, the next step is to start building your case by looking at the predisposing factors. Let's really drill down on the profile of an at-risk patient. Who should be at the very top of your clinical radar for OSAHS?
So, no surprise here, right? The single biggest predisposing factor you're going to see time and time again is obesity. The link is just so strong from a physiological standpoint. All that excess fatty tissue in the neck and around the pharynx can literally narrow the airway, making it much more likely to collapse during sleep. But, and this is a big but, while obesity is definitely the major player, it is absolutely crucial not to get tunnel vision. You have to look for other underlying causes that could be part of the picture. And this right here, this shows you the whole range of other factors you need to be thinking about. So think anatomically. An enlarged tongue, macroglossia, could that be a sign of an underlying endocrine problem like acromegaly or hypothyroidism? And in kids especially, you've got to think about chronically large tonsils. They can be a huge culprit. And of course, don't forget those syndromic causes like Marfan's, where that connective tissue laxity can really affect the stability of the airway.
Okay, so why is this all so important? Why does catching this early matter so much? Well, because OSAHS isn't just about someone having a bad night's sleep. Not at all. It's a systemic condition with some really serious, far-reaching consequences. Let's actually quantify the impact of what happens when this condition goes untreated.
Yeah, the consequences are pretty significant, and they're systemic. I mean, of course you have the classic one, that debilitating, excessive daytime sleepiness. But those repeated cycles of low oxygen and then waking up, that puts an immense strain on the cardiovascular system. It can lead directly to systemic hypertension. And if you were to do a blood gas analysis, you might even spot a compensated respiratory acidosis from all that chronic CO2 retention overnight. It affects the whole body.
So how do we formally assess that daytime sleepiness? Well, you've got two main tools in your toolkit. First, there's the subjective one, the Epworth Sleepiness Scale. It's a simple but really effective questionnaire for the patient or their partner. And then, if you need a more definitive objective measure, you've got the Multiple Sleep Latency Test, or MSLT. This one actually uses EEG criteria to measure, very precisely, how long it takes a patient to fall asleep in a controlled lab setting. All right, so let's recap. We've built a pretty strong clinical picture from the history. We've identified the risk factors. We've even quantified the sleepiness. Now for the final and most crucial step. How do we go from a strong suspicion to a definitive, rock-solid confirmed diagnosis?
The definitive investigation, and listen, this is the gold standard you absolutely 100% need to know for your exams and for your practice, is polysomnography. Now, this isn't just some simple overnight oximetry test you clip on a finger. No way. It is a comprehensive, multi-channel sleep study that gives us the full, complete picture of a patient's sleep architecture and their physiology.
And let's be clear, a full polysomnography is so much more than just overnight pulse oximetry. It is a highly detailed, multi-system assessment. We're talking about measuring brain activity with an EEG, respiratory airflow, the actual effort of breathing through thoracoabdominal movement, snoring, and yes, of course, oxygen saturation. This is what truly confirms the diagnosis and, just as importantly, grades its severity.
Okay, you've done the work, the diagnosis is confirmed. Now for the really critical question. What are we going to do about it? Let's walk through the current evidence-based treatment algorithm for managing OSAS. So the management strategy follows a really clear hierarchy, and the foundation for literally every single patient is lifestyle modification. We're talking specifically about weight loss. Now, for folks with moderate to severe disease, the first-line therapy is CPAP, continuous positive airway pressure. You can think of it as a pneumatic splint, just holding the airway open. Then, for milder cases, or for patients who just can't tolerate CPAP, intraoral devices like mandibular advancement splints are a key alternative. They basically just pull the jaw forward a bit to open up that airway space.
Now listen up, because this is a really important point, both for your patients and for sure for any specialty exams you might be taking. Right now, there is very limited evidence to support using any kind of pharmacological agent, any drug, in the routine management of OSHS. The focus really remains on lifestyle and devices. That's where the evidence is. And finally, we absolutely have to talk about a pretty significant medical legal responsibility here. If a patient's OSHS is causing that excessive daytime sleepiness, you have a professional duty to advise them that they must inform the National Licensing Authority. In the UK, that's the DVLA. And look, this isn't just about paperwork. This has major public safety implications. It's a conversation you absolutely have to have with your patient. So let's end with a thought to take back with you to your practice. You know, with the rising rates of obesity all over the world, we really have to ask ourselves, is obstructive sleep apnea the next big chronic disease crisis? And maybe more importantly for you, how is that increasing prevalence going to impact your clinical workload in the years to come? Something to think about.